Thank you. So we're just going to move on and talk a little bit about sepsis in maternity, and I'm going to set the scene, although I don't think I need to do that terribly much to this audience or to emphasise the potentially devastating effect that sepsis can have in the maternity setting. And then Linda's going to go on and talk a little bit about some of the work that's happening in Tayside. So you may or may not be aware of this document. This is a UK document. It's a confidential inquiry into maternal deaths. And it's a document that has been running in the UK since 1952 and is fairly unique worldwide, I think, in terms of this, in that all maternal deaths in the UK are reported and are looked at in detail. And the latest confidential inquiry was published in 2011. And in the time period that it looked at, 2006 to 2008, 261 women died. And by definition, those were women of childbearing age, young, healthy women who, for the most part, entered pregnancy fit and healthy. And that left more than 400 babies and children without a mother. And when you look at how sepsis is incorporated into this, the maternal mortality rate is decreasing, and that's great. And it decreased from just under 14 per 100,000 maternities in 2003 to 2005 to just under 12 per 100,000 maternities in this latest confidential inquiry. But despite an overall fall in the number of maternal deaths, there was a rise in the number of women dying from sepsis. And in fact, infection was the leading cause of maternal deaths for the first time since this inquiry began in 1952. And that really is pretty much down to a rise in Group A strep sepsis. And within this document, that meant that 29 women died, and they are classified as early if they happen within the time of pregnancy or within the first month afterwards, or late deaths, anything up to a year is recorded and looked at. And in two-thirds of those women, lessons could be learned from what happened. And in a third of those women, it was felt that the outcome might have been different if the infection had been diagnosed and treated more promptly. And the inquiry comes up with top 10 recommendations, and sepsis was most certainly up there in this most recent document. So what are we doing in the maternity patient safety programme? This is our driver diagram. We're looking to reduce avoidable harm in women. And down here in our safe, effective, reliable care is the deteriorating patient, Muse and sepsis. So it's really important to our programme. And our programme was launched just in March this year, so we're the baby of the family, excuse the pun. But sepsis was a big part of our second learning session, which was just in October of last year. And there's been a lot of work from our maternity teams and our clinical reference group to take sepsis forward. And there was an appetite, certainly in that learning session, to get national agreement for SIRS criteria. Now, maternity physiology is different. It's different from acute adult, it's different from paediatrics, and much of the information that's out there refers to adult and paediatrics, not to maternity. So there's quite a bit of work to be done amongst that just to make it relevant to maternity. However, I'm very pleased to say that we did achieve and launched our national SIRS criteria in March of this year, and so there's been a lot of work going on locally around that. And so I'm just going to hand over to Linda to talk a bit more about that.
Okay, in NHS Tayside, it had been kind of recognised about 2010 to about 2012 that there was really quite an increase in the amount of women having infections in maternity services. So there had been a rise in incidence of quite severe infections as well. There was a recognition that we had a lack of recognition of potential sepsis or the treatment of infection, and a lack of escalation. Because of some of the things that Corinne had said there, that maternity is a little bit different, and that's how people actually think, so they will put a tachycardia down to, well, she's in pain, she's got a bit of a temperature, well, she's labouring, so we could talk away a lot of the women's response, and we gave paracetamol. couple of paracetamol. So, you know, for all these reasons, we were sort of really not recognising or not escalating appropriately. There had been an increase in long postnatal stays and readmissions as well. And we'd had several cases resulting in hysterectomy. Now, bearing in mind these are healthy women, you know, at an age when they should be able to come in and have a baby, and yet they were leaving having had a hysterectomy. And we had a maternal death, a young girl, and it was related to sepsis. So clearly something had to be done. So what did we need? We needed early recognition, assessment and treatment. Working with, and this was prior to, I am one of the maternity champions within the QUIC programme, that's the Maternity and Child Quality Improvement Collaborative. Prior to that, Dr. Lynch, who's one of the consultants at 9 Wells, had you know, decided that, you know, we really needed to try and do something about this through the SPSP group in Tayside. They heard about the Sepsis 6 tool, which was being used in acute services, and thought, you know, that sounds like maybe just what we need. So they got that tool. I had to do quite a little bit of adapting. We're actually just moving on to version 9 of that, so that'll tell you that there's quite a little bit of work done just to try and get that right, because remember, it's about escalation, appropriate you know, recognition. So it was just trying to work with that around surge criteria and use. And although we've got that national definition now, we didn't have it then. So the Sepsis 6 tool had gone through, and I'll show you that shortly. Also, there was working with the antibiotic management group in Tayside. Maternity Services did a lot of work around guidelines and protocols around antibiotics and using the appropriate antibiotic, which was really important. And we've got what's called the antibiotic woman. It probably doesn't show as well here, but it's in all areas. Just the picture at the top, and you know, it's large, and it has very clearly the recommended antibiotics that you should use depending on what infection you're thinking of. And also on the Sepsis 6 tool, it has the clearly defined antibiotics that you should be using. So it takes some of that guesswork out, because when we looked at it, you know, through reviews of some of the treatment, it was, you know, antibiotics, it depended on who was on that day. So it was. So this makes it just very, very clear around, you know, what you should be using. And this is our Sepsis 6 tool as it is just now. Although again, as I say, we're just moving on to version 9 at the moment. And we Kevin was saying there at the beginning about the news, and it was one of the things that just going with SIRS was quite difficult in maternity, because, you know, they can be masked with tachycardia, and so for us the trigger is one red, so that would be a temp. It doesn't necessarily mean you would commence the Sepsis 6 tool, but it triggers your assessment, you know, because again, going back, we needed assessment and recognition. So one red would trigger an assessment, and then underneath, you know, if you've got no sepsis response greater or equal to 2, then you could opt out. So we've done quite a bit of work, but what we wanted was that staff made an assessment and a plan of care around, you know, what am I thinking here, and what am I thinking about the whole picture, rather than just that one-off temp. You know, what has led up to that, or what else do I need to be thinking about? This was just, for example, I came in as maternity champion, and it just gave us a chance to have a look. The tool had been put out in maternity services as things happen, and some people knew about it, some people didn't know about it, so it wasn't really being used very reliably. So we did quite a little bit of work once I got my head around PDSAs and things. And this is just a little idea of some of the steps that we went through to try and make this a really robust tool, and to be able to audit it well. This, for example, our timing for our first antibiotics, so we started in November 2012, and as you can see, it was very sporadic. We still had, you know, quite significant delays sometimes in getting first antibiotics started, to where we are now. You know, so much better. And that was interesting because one of the things that we were told was that the most difficult thing would be the antibiotic within an hour. You know, it would be impossible to get medical staff there in time, you know, and there was too many other things to do. So this was, we thought, our biggest challenge. This is our compliance now. So we started back in November 2012 at 38% use of the tool, and you know, going through various, looking at ways of trying to engage the staff, trying to make sure that people knew about it. So there was a lot of raising awareness, a lot of staff training. We now have sepsis on all our training, so regardless of what you're doing, whether it's a prompt or whether it's a more just small group face-to-face, you know, we have a sepsis talk. We also talk about it at safety briefs, and the compliance, as well as put up and run charts, and also as a percentage every month in maternity services, and we feed back to individual staff when they maybe haven't acted quite appropriately. So we went on the various different tests there, you know, improving the response time, automatic blood test requests. We found that was a great. So on ICE, which is our electronic blood requesting system, we've actually got sepsis bloods there now. So if you know, you just print that and it will give you all the labels, which means nobody will miss anything because the labels are there and they're like, oh, what's this one for? You know, so that's been really good. And we've also just added the swabs to that as well, which is fantastic, because again, sometimes people were forgetting to take a throat swab, or you know, but in doing that, it means it takes the guesswork out of it. People just and it's done, click of a button, and you know what you've got to do. Lots and lots of feedback. You know, I have found the small teaching sessions to be the absolute best way of doing it. Discussion with staff, because I think if they understand the why, then they're much more likely to comply. You know, with, because they understand why, and they've been there where that, you know, that woman has died, you know, so it's very much, and it's not something we're used to in maternity services, you know, it's something that really can bring you up. Blood cultures, we had a little bit of a problem sometimes. So the IV antibiotics in the end didn't end up being a problem for us. We found that actually we could get medical staff to respond quite quickly, and most of the midwives give IV antibiotics, so that was actually quite a straightforward process. We didn't have a great problem around you know, fluid balance, because in actual fact in maternity we're obsessed with urine and fluid, so that's actually hasn't been too bad to have that done. Blood cultures, so there's a little bit of delay of them, because again, sometimes medical staff, if they were in a rush, they can quickly prescribe antibiotics, but to take the time to do the blood cultures was sometimes an issue. So we've now have the midwives trained to do blood cultures, and apparently they do it much better anyway. Sorry, medics amongst us. That's both medical and midwifery, you know, opinion. So continual audit and feedback. This is just for example, in the early days, you know, a 22-year-old insulin-dependent diabetic woman, 34 weeks gestation, she was admitted from the diabetic clinic with a deranged blood glucose with suspected infection to the observation area in our labour ward. She had the bundle commenced, so again, somebody said, oh, I better go and get that sepsis bundle. Some of the elements were completed. There was a delay in the administration of the antibiotics by something like 4 hours, 20 minutes. You know, so bearing in mind, this woman is, you know, she's an insulin-dependent diabetic as well. And there was no accurate assessment of urine output. Again, because she was admitted antenatally, then she hadn't, you know, been really appropriate assessed. It was a busy day. There was staffing issue, you know, observation area was full, but there was no sense of urgency really, and she remained an inpatient for 5 days, recovered well and went home, and came in a few weeks later to have her baby, and all was well. But it just it was just highlights some of the problems, you know, around when it gets really busy and everybody means to do something, but there was a delay for this woman. You know, once the tool was really quite well established, this was a good example. A 28-year-old woman in labour, and this woman had spontaneous ruptures of membranes, you know, so over 75 hours. And generally in maternity services, we would, you know, recommend augmentation after 24, 48 hours. Because there's an increased risk of infection once you start to get over 96 hours, I think it is. But this woman wished what we call conservative management. So she was happy, she knew what the risks were, but she wanted to labour in one of the midwifery units, which was about 20 miles away. However, she did develop quite a significant temperature and a tachycardia. Now, the midwives recognised that right away. She had immediate transfer to 9 Wells. But what they did, and what we're really keen for staff to do, is to use SBAR communication and say, I have commenced sepsis 6, so that everybody knows, actually, I've got an hour to actually get that woman here and get all that commenced. And this is exactly what happened. So this was a really good example of team working and appropriate communication. Rather than just phoning up and saying, oh, I've got somebody that's got a wee bit of a temperature, it doesn't really, get that sense of urgency. So good recognition, good assessment, and appropriate timely care. So a really good example. Coming from 20 miles away, in by ambulance, they were all ready for her, and carried on. And this woman, she was in the unit for about an IV antibiotics for about 48 hours, so it didn't just resolve. There was issues with this lady. So successes and challenges for us. The mini teaching sessions, I find really helpful with the staff. It is more time consuming, but actual fact you get so much more out of it, because staff actually understand rather than just a wee memo coming round and they're thinking, why are we doing this now? And regular feedback and discussions with the staff, everybody's responsibility. And this was quite important because, the midwife would just say, well, I phoned Dr. So-and-so, and they never came, and Dr. So-and-so, yeah, but you never said that, so there was this about communication. So really what we emphasise with staff is, if you were even if you were the student midwife and you had come across and that woman had these appropriate triggers on the muse, then it was your responsibility to escalate that. And using SBAR communication as well. Some challenges, thinking potential sepsis. We still have a little bit of, everybody and their auntie seems to be on antibiotics these days. That's a quote. So again, just trying to be really robust with our risk management and our assessment and audit as well, to make sure that we aren't, because we don't want to overly treat women, but again, we don't want to undertreat them either. And we're continuing to do more work around that. We've got a research study that some of the doctors are about to start on, looking at the bloods, the specific bloods, what is actually normal lactate and CRP for labouring women, postnatal women, because as far as I'm aware, there isn't a great deal of evidence out there. So we're continually looking at that. Recognition of triggers. So again, just appropriate use of muse and adapting that again to make sure that we're using it really well. Consistent application and use of the tool, and really getting away from the busyness culture. So this is for every woman, every time, regardless of how busy it is or how who's on that day. This is just what we do. Future plans, as I say, audit and to reach and maintain over the 95% compliance, ensuring antibiotic stewardship and the appropriate de-escalation, and that's become very much part of the daily consultant ward round. So again, it's really important that happens as well, and we're going to figure that into the tool, so that there's an appropriate assessment within so many hours of doing that and looking at the blood results. What are they telling us? It's telling us we need to carry on. Are they telling us we need to escalate it further? What's the information there? And continue to ensure appropriate follow-up for women on discharge to prevent readmission, because we found that for a while, we were having a lot of women coming back, whereas now we don't have that quite so much. And just a continuous review of the tool and the guideline as well. There we go. Thank you, and I'm handing over to Professor